Okay, welcome everybody. My name is Andrew Weeks. I'm president of the Liverpool Medical Institution this year. So, welcome to those online. This is now the 14th of 20 in our series of lectures on bringing life, looking at maternity, especially in the UK. What's happened? What are the issues? We hear a lot about it in the press. We hear a lot about it on TV. But what does good life look like? What are the issues? And we've been exploring them over through the years of lectures. And I'm very delighted tonight to have Professor James Walker, who's come across from Leeds, to talk about what does good look like for maternity services. Um, uh, Jimmy, as I worked with him, he was my first boss in Liverpool, I guess, in Leeds, but is emeritus professor at the University of Leeds, and set up the HSIB, which was the Healthcare Safety Investigation Board, which did a lot of the early work on trying to produce a non-punitive, independent assessment of issues when outcomes were not good. That's now been replaced by MNSI, but his huge experience then is pertinent to this. And especially as we hear there's over 700 recommendations from the various reviews going on around the country, how can we try and pull those all together? How can we make sense of them? And in a sense, we've got later on as our final lecture, we've got Alex Heasel speaking, who's part of the AMOS review team, who will tell us, I guess, the correct view, but you can imagine that's going to be carefully couched and it's quite political, etc. Whereas one of maybe the benefits of Jimmy being around is that having been there and walked the walk and talked the talk and now emeritus, you can speak a little bit more freely about what does good look like for UK maternity services. So, Jimmy, thank you.
Well, thank you very much, Andrew. Andrew was one of my first doctorate students in Leeds. So and it's amazing how well he's done since then. So, but it's a pleasure to be here, and thank you for inviting me. It's lovely coming to institutions like this and think about what lectures were given in the past and what people were talking about. And it's interesting. I always remember looking up. I had a whole range of the British Journal, used to be of the British Empire, and you take one of these books and open it up at any page in any paper, you see something very pertinent to today. That someone's done some work, and all you could do, you could take the same idea and use modern techniques and come out with a new paper. So a lot of things in maternity, I think, has been talked about before. And those who heard one of my lectures in the college about a couple of years ago, I talked about a presentation to the Edinburgh Society in 1900 that talked about moving radiology pictures and factors relating to what people saw as what the future in obstetrics was. Anyway, what I want to do is to talk about what does good look like for maternity services. And what I want to try and show you really is that the idea that there's anything particularly bad about maternity services is actually overstated. There are things bad about maternity service that need to be improved, but that's true actually across all the healthcare services, not just maternity. But there are also some very, very good things that we've done. Why is that not working? Okay, well, all right. No, that's over there. Okay, I'll use that. That's just as a list of things I've been and done in the past, which is that Andrew sort of hinted at, and I won't pause on it. But it means that I've seen a lot, done a lot, and I can talk from a fair amount of experience. So how do we get to where we are today? And I want to look at history first of all, because it's always important to look at history, because you learn from history, and you can get a lot out of what you should do today from it. We started when childbirth was historically a very uncertain thing. People never knew whether the baby was going to survive at delivery. Even I remember when I started in the late 70s, early 80s in obstetrics, is you never really knew how many babies were there, and you never really knew which way around they were when they were coming out. We tended to know whether they were alive because we had pinhole stethoscopes, and in fact we had CTG machines at that time. But in general, there was still a lot of surprise because we didn't know an awful lot about what was going on. The pinhole stethoscope was developed in 1885, and it could detect the fetal heart rate. So then you got to the point where we could hear a heartbeat, but we couldn't really hear the warning of what it meant. Obstetric forceps developed by Chamberlain's in the 1600s, but it really wasn't widely used probably until the 1800s when it was sold on from one of the Chamberlain's offspring, and it then got popularized by other people around the world. So these things all helped to move obstetrics from totally unknown into a more modern age. So we've done very well, really, and this is what happened in the early 1900s. That we started lying in hospitals in places like this was the Royal Maternity Hospital in Glasgow, on the top right there, and but there's others in Boston and Dublin, etc. Caesarean section was first popularized around about 1900. Had happened before, but it became popular in use. And these three women in the picture there were women who had rickets in Glasgow and could only deliver a live baby by caesarean section. So intervention in a known risk group was something which then started sort of moving towards modern obstetrics. Community midwifery started in the 1930s, which allowed, or developed fully in the 1930s, which allowed women to be seen by midwives and to get advice and help and support from them. And early natal care, but that only really consisted of drying and stimulating and keeping them warm. They couldn't really do any other intervention. But if you look at maternal mortality over that period of time, from the 1850s through to about 1940, that it was still high. It didn't really fall very much despite these interventions, and despite things like aseptic techniques and other things which were around at the time. It wasn't until the late 1930s and into the 40s they had this dramatic fall of maternal mortality, and that associated with the time of the Second World War. At that time, in 1940, there was 290 deaths per 100,000 women, about 1 in 345. And the main causes were sepsis, hemorrhage, and convulsion or preeclampsia. But at that time, sulfonamides, then penicillin came along, blood transfusion, ergotamine, although it was around since about 1935, safe anesthetics, and skilled doctors and nurses. And what that allowed us to do is intervene. So we then developed a process of risk assessment of people who we thought were ill, escalate that to someone who could do something about it, and intervene by giving them blood or giving them antibiotics or having a caesarean section under safe anesthetics. That had a huge dramatic effect on maternal mortality, just these three things. And in fact, penicillin, blood transfusion, and safe anesthetics were probably the three greatest obstetric advances in the 19th century, the 20th century. Now, if you then look at shortly after that in developments in natal care, this is Virginia Apgar, who is an anaesthetist, who was called to see a baby that was flat because she happened to be around, and she said, "Why don't we score it?" And she developed the Apgar score. And what that did is told people what was a sick baby, escalate that to then do something about it. But in fact, there wasn't a lot they could do about it. They didn't intubate, they didn't ventilate at that time. It was anaesthetists did that. And it was through the 50s and around about into the 60s that anaesthetists started teaching pediatricians how to intubate and how to ventilate. So haven't we done well? Because we've got advances in midwifery care. We had hospital births, which had greatly reduced mortality at the time. We got neonatal care, which then followed on the work of Virginia Apgar to allow intervention and survival of the small neonate. We measured blood pressure, and so therefore, and lowered blood pressure, and developed protocols for preeclampsia, which has developed reductions in deaths. And it's interesting now that preeclampsia is a minuscule cause of death relatively for pregnant women in this country, rather than being one of the top two as it used to be even just in the 1980s. CTGs have made a big improvement, although it's difficult to prove its benefit, but the additional information it gives you during labour helps to assess when intervention is required. And of course, ultrasound was a big advance as well. What this has done then, looking at maternal mortality, looking at 1940 down to what happens now, there was about 290 deaths per 100,000. We're down to 10 per 100,000. These are dramatic falls, but most of the falls you could see happened by the year 2000 or thereabouts. So now, in most of the developing world, in the low and medium income countries, the maternal mortality is about the same as it was here in 1940. So there's scope and there's ability to get these figures down by doing some of the work that we've done in this country already. If you look at perinatal mortality, there has been still a steady fall in perinatal mortality, both stillbirth and also neonatal deaths. So they've improved over the same period of time, with, as you can see, about 1,000 fewer stillbirths in 2022 compared to 2013. So dramatic falls, dramatic improvements. And modern maternity, therefore, an average unit in the UK saves about 15 to 20 mothers' lives a year just by doing normal things, by lowering blood pressure, by giving antibiotics, by giving blood transfusions. Perinatal mortality, similarly, about 150 to 200 babies' lives are saved a year purely by delivering them at the appropriate time, intubating them, ventilating them, and helping them survive, just giving that ability to survive in the first few minutes. Great improvements, and therefore we should be proud of the work we do. And the midwife is the linchpin. One of the advantages of midwifery care in this country is the midwife and the integration of midwife into the overall obstetric care. They're not largely dependent, as they are in many other countries, but they are integrated in. Their first contact with most women, they're the primary assessor through pregnancy, and they're one who must recognize the situation and escalate. Midwives can't rescue women and babies on their own. They need the linchpin of getting the right people there to help with the rescue intervention process. So they require support, supervision, and the psychological safety that allows her to act. But they also need close linking with obstetricians. We must work together and trust each other to work in that sort of teamwork. And it's this progress of maternity from risk assessment, make sure you get the woman and the baby in the right place at the right time, escalate when things go wrong to getting help when required, and rescuing when intervention is required after escalation has occurred. By using these three sort of terms, that's the basis of maternity care and the basis of good maternity care. And if we stop watching and escalating, it stops being safe. This is a figure of the maternal mortality in Iraq over the time of the Iraq wars. As you can see, that the maternal mortality rose, not because they were bombed, because the maternity services were diminished. It's happening in Ukraine now. It happens in areas of earthquake, anywhere natural disaster. Maternal mortality rises dramatically. It's the same women, the same diet, the same upbringing and genes. The difference is they don't get the medical care. So if you start reducing the medical care and the appropriate care, you get a rise in maternal mortality. And what we're seeing in the UK now, in these figures, and the top figure there is the overall maternal mortality. About 2013, we had the lowest maternal mortality that we've ever had in this country. And since then, it's a plateau at that time, and it's started to rise in the last few years. We started to take our eye off the ball. We're not quite as good as we were. Neonatal deaths still have continued to fall, although there's been a slight rise in neonatal mortality in the last few years. So therefore, the improvements that we've seen over a long period of time has begun to slow or reverse. So we need to think what we need to do about it. Now, one of the other things that's happened in the last 10 years or so is the great increase of people who are concerned about maternity care. Families who've had bad events, who are and have grievances about the care received. And this has led to the rise of the inquiries. First inquiry was the Morecambe Bay. Well, it's not the first one, but the one of recent times, Morecambe Bay, which I sat on with Bill Kirkup. And then the Shrewsbury Telford one, there's East Kent, there's Nottingham, and then there's now Leeds starting this year. And you can see, in fact, the first 3 or 4 are actually covering the same years, just in different hospitals. So this is not a progression of something happened and it's happening again and again. It's something happened and it's happened somewhere else and happened somewhere else. So the message from the first 4 are not that this is a progressive, non-improving situation. This is a national problem of maternity services. Now, the National Investigation Programs started with HSIB, it started in 2018, which I was the inaugural clinical director of. And now, in fact, after MSI took it over, we have 4,600 investigations across all trusts in England. The Parliament's inquiry of maternity safety that came out in 2022, and also the most recently the work from Baroness Amos of the National Maternity Natal Investigation. And what they found was what everyone else found, and that is capacity pressures, culture and leadership problems, racism and discrimination, poor responses and lack of accountability when things go wrong, and the quality of the estates, of the buildings and so on, and the workforce. These are all things that have all been highlighted in all the other investigations and inquiries. So we don't need more and more inquiries. We need to do something about it. So these findings aren't new. The same issues, communication, escalation, risk assessment, have been described for decades. The difference is now we see them clearly, repeatedly, and at scale. This is a national problem, not a trust problem. And that's the most important thing Baroness Amos's report has come out. This is not a hospital trust problem. It is actually a problem everywhere. And stop blaming trusts, stop blaming individuals, and start looking at why the system is failing. Frustration is that recognition does not automatically lead to change, because we need to implement change. And the problem at the moment, there's no one with any responsibility to take that on. Bill Kirkhope said that when he did the second report in Kent, that when he reported in Morecambe Bay in 2015, he didn't imagine for 1 minute that I'd be back 7 years in time talking about the similar set of circumstances, same themes in everyone, everywhere. So, as I said earlier, the reason for these inquiries is they come from families that have pressurised from them, and we failed them, not as far as they're concerned, not necessarily by the incident, but by not being transparent with them once the incident has occurred. We don't tell them what happened and give them an explanation of why it happened and how we want to improve it. But in fact, we failed them 3 times. We failed them at the time of the incident, allowing it to occur. We failed by not telling them what happened, and we're failing again by not stopping them happening again. Most families, when talking to them about an event that has occurred, want to make sure it doesn't happen to the next person. So we've lost our way. We've got fragmented care now, silo working between specialties and settings. We've got professional tensions between midwives and obstetricians in the hospital and community. Low risk label has created a reduced vigilance and delayed emergency response. And really the low risk is now the new high risk, because if you're labelled low risk, no one expects something to go wrong. So you fail to escalate in a timely fashion. We're restricted by guidelines, trying to fit the patient into the guideline rather than using a guideline for the patient. Women will be central to care, but their safety is not. We're no longer ready, trained, or experienced for the unexpected. We should have a background of chronic unease, are persistently vigilant and never become complacent. And I don't know about any of you who've worked in this area, but certainly one of the things I always worried about is what could go wrong, not how wonderful everything is going. So what do the investigations, that's the HSIB work, tell us? Well, as I say, we're set up in 2017, and we've gone through to MSI, and we've now got, as I say, we looked at all trusts in the UK. They all were mandated to send in all their stillbirths, neonatal deaths, and babies that were cooled from women at term who have been in labour. And what we did was we looked at not just what we thought happened or what the guidelines said. We actually looked at the work as it was done, and why the system in some way failed to give the results that we wanted. We used models. This is the SEEPS model, which is the Safety Engineering Initiative for Patient Safety, where we looked at taking all the events around the events that occur. We looked at the estate, we looked at the support people had, we looked at the hours people had, we looked at the number of people on duty, etc. And then the process and how that process then progressed and what the outcome was by looking to see what the problems were. And the things we picked up, which is not a surprise, was there was problems with guidelines, clinical oversight, risk assessment, clinical assessment, communication and escalation. And you can see from the percentages of frequency that many of these cases many had more than one of these events there, some several. And it's event inevitable because this is the pattern. To actually risk assess properly, you need to be trained and understand what the risks are. You need to have guidance to know how to classify the risk. You need to communicate that with somebody. If there's a problem because the risk has escalated, you need to go to escalation. Again, that needs communication. You need to be trained to be able to escalate. You need clinical oversight and clinical assessment to escalate, and then you go for intervention. And again, that requires clinical training and so on. So they're all interrelated. So if you have a hospital that has bad communications between their staff, the whole thing collapses, because that's one of the cogs in the wheel. They're all necessary to be successful. And you can see here that an example of a clinical situation where a woman in labour told repeatedly she was not in labour, assessed technically correct, her cervical threshold was not met, she wasn't 3 centimetres, so she didn't get into labour ward. Guidelines were followed, no individual fault found. She delayed returning to the hospital because she didn't know when to come back, because as far as she's concerned, she was in labour the first time. Baby born later with fetal compromise. So the analysis showed with organizational rigidity, guideline applied without clinical judgment, midwife felt unable to escalate concern, not supported by other staff, environment did not support individualized care, and hierarchical barriers prevented action. The problem was not the condition, it was the system. So to escalate, we've got to get rid of properly of hierarchical barriers. We need proper trigger tools and not just depend on the good people to be there. An adequate response when a concern is raised and the concern is noted but not acted upon. We've got delay. The delay is the problem. Delay of escalation to rescue is the main problem to get poor outcome. Not a lack of knowledge, but failure to act on it. When a midwife is not heard, the baby pays the price. And these conflicts are across not just obstetricians, midwives, but between hospital and community, labour ward, antenatal ward, etc., etc. So these barriers, these silos, means that it's broken down the care which used to be sort of allowed to flow and to work amongst all the people involved. So, interesting enough, COVID-19, which tested our hospital system, and all the cases of stillbirth and problems of neonatal death and cooling all rose during the COVID time, not because of the virus itself, but because the system was failed. Very similar to what happened in Iraq. If you destroy your system of normality of how to care for someone, the care it diminishes. So the investigation alone is not enough, because most of the recommendations, and Andrew talked about the hundreds of recommendations that put out, they're often quite weak, they're non-specific and not implementable. There's no clear ownership in the trust. There's absence of measurement of change. We don't even know if interventions and the recommendations work. Investigation generates insight but does not guarantee implementation. The same lessons have been described for decades. We have the tools, we have the will, so why don't we do it? Now, one of the important things we did in HSIN, and this is our process that we went through of scoping and investigating, was the feedback. We had feedback to the family, we fed that to the trust, we linked it to the LMSs and ICSs, and we reported to the board, CTGs and chief midwives. So everyone knew about them. We discussed with them how to implement any recommendations and learn from it and where we can move forward. And what we found, and these are the results from 2021 through to 2024-25, you can see a dramatic fall in the number of cases referred to us as being at risk of either potential severe brain injury or complications of that. And you can see that also that stillbirth hasn't changed, but the severe birth injury, there's 110 less per year. The early natal death is 33 cases less per year, and we're now seeing 17 less maternal deaths per year. This is the latest figures in the last few years. Now, remember, these figures are newer than the embrace figures, embrace figures is always 2 or 3 years further back. So we believe that partly the work that MS and I did by getting information, telling trusts what they were doing wrong and how they could do it better has improved outcome. If just 1 or 2 of these severe birth injuries don't go on to sue, we've covered our costs for about 5 years. Every case is about 35 million, and there's only 16 million to run MSI. So it looks as if it's a very good, cost-effective thing. So this is part of the continuous improvement cycle. Have an incident, investigation, we learn, a system must then redesign, and then we improve the outcome. So it can be done with the right tools and the right encouragement. So the problem is, and this is something that's increasing in the last few years, is the problems of psychological safety. It's a paradigm shift. In the last decade, we've moved from clinical risk to emotional and physical and psychological safety. The 2024 birth trauma inquiry showed that psychological safety is central for women who are going through the maternity system. But it's same for staff. They're the second victims, and their experience matters equally. The distinction is that being safe versus feeling safe. And without psychological safety, staff cannot escalate. The system breaks down. They don't have the courage to escalate. They're scared to escalate. They're scared to make decisions. And what feedback we're getting is that our staff don't feel psychologically safe from reviews that are occurring and are happening. It's changing people's practice. Midwives feel scared. Inquiries in the maternity care are probably damaging maternity more than anything else has done in the last 20 years by destroying morale within the system. It's the staff in the hospitals who we are dependent on to actually make the changes to improve the outcome. If we destroy their morale and their feeling of safety, they can't improve the service. We find a problem, we evaluate it, and then we have no agency to change it. A lot of people are frustrated in hospitals because they know what they want to do to improve things, but they can't change it because they don't get permission to do it themselves. And this picture is Fleetwood Mac, in fact, but I use this to try and show that you may have some prima donnas at the front who feel that they're the big people, but in fact, they're totally dependent on everybody else in that picture. The lighting man, the sound man, the backing singers, they're all important. So the idea that it's all about one person or the most important person is not true. It's about everyone, because Lindsey Buckingham can't play his music without people who are singing for him or drumming for him or working the lights. So we're all dependent on everyone within our systems. So we've got the same issues. Communication, escalation, risk assessment have been described for decades. The difference is now we can see them clearly, repeatedly, and at scale. So where should we go from now? No more inquiries. We should not have any more big inquiries, but the families do need answers. So we need some sort of system to give families open, transparent answers, but not big inquiries that take years and cost millions. We know what to do. Why don't we do it? Accept mistakes were made, be transparent, discuss the reasons, discuss the solutions, be empathetic. Involve everyone, families, staff, experts, and safety scientists. We should go back to basics with adequate staffing in all areas, not just for the expected, but the unexpected. Supernumerary positions to provide oversight. Remember the days of the SR around Labour Ward. They were the most important people because they covered the back of everyone else. But don't promote midwives into core specialist jobs to the detriment of core staff. We have joint skills and drills. We do that reasonably well now with things like prompt, backfill for training. Listen to ideas from staff for improvement, embrace diversity, get skill mix right, and maintain it. And moving forward, we acknowledge the importance of the job. We acknowledge that our staff are in a trauma area. They suffer trauma from the events that occur. We need to care for them and give them the support. Metrics that make psychological safety count in quality indicators, so we know what our staff are feeling. Humility and communication with patients and with colleagues. Be receptive when someone looks for help. Restorative, not repetitive, the response when things go wrong. So what good looks like? Dynamic, continuous risk assessment, not binary or static. Integrated care for all women, regardless of risk label, with rapid escalation pathways. Structured escalation triggers that work whoever's on shift. Rescue teams that rehearse. In the airline industry, the air hostesses spend 90% of their training focused on what might go wrong, not how to pour tea. So they know that they need to respond when things go wrong. Using things like PSIRF and seats to lead from learning when it drives the change. What we must do is get these right for adequate staffing, with reinforced positivity, encourage reporting, allow development of individual and team. Do not try and be too clever. The simple, basic stuff is what's important. We're all there for the same reasons, the health and safety of mothers and baby. So get back to basics. designed for 2030, not 1980. Build partnerships between clinical staff and between women and clinical staff. Build psychological safety for women and their families, for all staff. Give agency to all to question and change. And remember that we love our jobs, just help us to do them. Thank you.
Thank you so much, Jimmy. Are you happy to take some questions? Yeah, no, fascinating. Can I start by asking you a question? I mean, there seems to have been a breakdown in trust, somewhat between the women who are under our care and the hospital services, and that's leading to such problems. That is, of people choosing their maybe it's not a problem, but people choosing to do what they want to do rather than taking advice. But that seems to be because they believe that it would be a better thing to do rather than because it's because of that lack of trust. Or of people, I mean, I see people in my section list every week coming through and wanting a section not because there's a strong indication for it, but because they actually don't trust the service to get it right. Can we rebuild that trust, do you think? How do you see that moving forward? Because that seems to be central to the whole process, that the trust has broken down.
The trust has broken down, and I think we can rebuild it. But I think that we've got to think about why it's broken down. One of the problems is rigidity of practice. We have guidelines now, so therefore, if women come in and don't fit the guideline, we tell them we can't do that. For instance, the story I told you about someone coming in who thinks they're in labour, she's got pain, she wants help, she wants analgesia, but if she doesn't fit the guideline, and she's not 3 centimetres, she's not in labour, therefore she doesn't get analgesia, therefore she doesn't get the care and support she requires. And then she goes home, and therefore she even gets less care than she requires. So that's we should have a situation say, okay, she doesn't go into labour ward, but there should be somewhere else that she goes to get the help and support. So it's that sort of feeling that we're caring for the individual and what her needs are, rather than telling her that she doesn't fit into what we think her needs are. So that's one of the factors. The other thing is that I think because of the degree of publicity that's around about the care and the criticisms of the inquiries, then a lot of women have lost trust. I mean, these instances that we saw in ACE, that's only 1.5 cases per 1,000 births. It's a very small number. It's important for the individuals that they are, but it's a small number. It's still the vast majority of women go through and have their babies very successfully and very safely in our practice. But that's not what people believe. They see these horror stories and think that's the norm.
Yeah. No, it's been a shock. The graph you showed of the reducing in perinatal mortality over the last 20 years, and the message that there's never been a safer place to give, never been a safer time to give birth than today, seems to be lost in all the discussions, and that's all very sad, because the potential is that then actually that will cause problem to the improvements to reverse when people no longer want to trust advice that they're given, or indeed to de-escalate the huge cesarean section rate will come back and bite us, surely.
Yes,
when people have their second births, third births.
Well, the problem is I published this, I was saying earlier, some years ago, in about 1998 or something, I think. And it was the fact, if you have a cesarean section, 35% of women are infertile afterwards. They can't have another baby. And it may be partly they don't want one, but they don't come back for another one. So, and the average number of children people have is reduced. Now, that's true anyway in this country for other reasons. But cesarean section is not the simple answer. There's complications to cesarean section. And of course, the placenta accreta problem is something which we see more and more of the adherent placenta on the old scar. Look at the questions coming in.
Yes, I'm going to try and negotiate at the same time. Listed. Are there any questions in the room before we take them online? Maybe just at the back first.
We have a really, really good time proposal. I believe it's because the system was used. I don't think it's used anymore. We had a midwife, Stephanie Blanchard. She was a domino midwife. So we were at home. She saw us right the way through the pregnancy. When my wife went into labour, we rang her when it was like, I can't remember now, I would say 3 minutes. She then drove round the corner. We drove there. She delivered both children. She knew loads more from the consultant who turned up later on. She was fantastic. But we felt safe, we're secure, and we trusted her. Now, I don't think that system is used anymore, is it?
That system in itself is not used anymore, unfortunately. I mean, community midwifery and community birth and support is there, but it's more patchy. The people, the midwives are not as skilled and experienced as they used to be before. So there's a significant problem with that. I think that again, I published previously on planned home birth, showing that the planned home birth can be very safe if it's integrated into a clinical pathway with trained midwives who link to hospital and know how to escalate and get women to where they need to be if need be. The problem that we're having now is that people, because they're not trusting the system, are going out with the system, and that's actually very dangerous, as I think you discovered in Liverpool recently. And the need for having what you're describing as a good trained midwife who knows what's going on, is there for you, but also links to the relevant people if she needs them. And remember, the majority of people, particularly people having their second or third baby, do not need medical intervention. So therefore, a good midwife will deliver or help the mother give birth quite successfully. So yes, we don't have that. Also, people are not trained so much. A lot of midwives are frightened to go into community. And the amount of support they have is give women in the community a lot less than they used to be.
Thank you. Should we take one of the questions online?
Yeah.
Yeah, there's a question here about feeling listened to. Women need to feel safe, and being listened to is a crucial part of that. It was a major thing for HSIB and MNSI now, is this sort of duty of candor, of being honest and transparent. And yet that, I mean, you've investigated, I mean, this is since 2018, and yet huge numbers of people don't feel they're being listened to when things go wrong. What's gone wrong? Because that should have been sorted, shouldn't it, by HSIB? I mean, you've seen all the bad outcomes. Why is that still a problem?
Well, I was sorry to say that it wasn't HSIB's role to sort it. It is your role to point out it was there. And one of the frustrations I had was I kept on saying we need someone here to help sort it and to take that. That wasn't part of our guidance or our limits. I think that women not being listened to is not just after an event; it's being listened to during their pregnancies as well. And the examples again in triage, when people come in and say, "I'm in labour, I've got pain," they're told they're not in labour. And and that conversation of telling a woman she's not in labour because of some sort of vaginal examination, it means that the women don't trust the midwife because, as far as they're concerned, they are. So it's this business of not just not being listened to, but also almost told that they're not telling the truth is the problem, I think. After something's happened, I mean, in the early mid-1980s, I started a clinic in Glasgow to see all the women who had stillbirths back to the hospital at 6 weeks with all the case notes, all the results, and sat down with them and talked through the whole case with them at that time. And I didn't see any problem in that. The hospital had no problem with that. And that's what we should do. And if something went wrong, we should talk to the women and find out why did it happen and help them to tell us, well, I asked for this and you didn't respond or whatever. That's the way to actually learn how to make it all better. But I think we've got to at the moment, it almost becomes, well, again, it started into the 2000s, where it was a lot of the trust lawyers actually started subjecting to people being honest with people. They wanted to say, well, we did the right thing, we followed the guidelines, rather than actually say, I'm really sorry this has happened. Let's see, what could have been done about it. So we've got to change that mentality and to work. And if we think our problem is that we don't have enough staff, that we need to communicate that with the families as well. Help them solve the problem. Help get them to help us solve the problem.
Yeah. Thank you, Derek.
Thank you very much. Thank you for a very thought-provoking talk. I wanted to take up two of the things which you mentioned, guidelines and investigations, because I think it's a totally toxic combination. I've built my observations from a career in surgery rather than in ops and guiding. What I've noticed over the last 30, 40 years is that junior doctors, now resident doctors, have become more and more risk averse. The number of times somebody said to me, well, I'm afraid that I might get sued about it, to point out that they will get sued, that the hospital will get sued. Didn't mention they full GMC, but that combination of guidelines, and I would say most of the work that I did, the complex work, was way outside the guidelines. And did it stop us? No, it didn't. Now people looking over their shoulder, whether they're complying with guidelines which don't fit the case. Then you get investigations. Well, I'm not talking about the sort of full hospital state investigation, but there's something went wrong and there's an investigation. What I've experienced is it takes so long that by the time there's any sort of meeting and conclusion, most of the people involved in the incident have actually moved on. So the opportunity to learn is zero. And not infrequently, actually the results of the investigation will be completely wrong. That's the other side of it. But I think what I'm really getting at is I think we have to re-empower doctors and nurses to take decisions, take responsibility, but absolutely not be afraid. If somebody's stuck with a guideline, then escalate it to the next rank up so that they can actually man up or woman up and actually get on and do what's necessary.
No, I would agree with you. I think that I've been involved in developing guidelines over the years, but the value of guidelines is when you want to do something. For instance, you want to lower someone's blood pressure. Is the red pill better than the blue pill? That's a guideline that you have that's been studied, and there's evidence to say the blue pill is better than the red pill or vice versa. So the problem is that we've then moved towards putting guidelines in for lots of other things. But you've got to remember that most studies that are done, randomized trials, have very tight guidance of who gets included in the trial in the first place. So in fact, a lot of the people you try and put into the guidelines would never get into the trial. So therefore, you don't know whether the trial works for them or not. So there's and the other thing with guidelines is that guidelines is only a guideline. It's not a protocol. It's not a rule. And people need to have courage to say, well, that doesn't work for this patient in this situation. I can take some information from it, but this is what I'll do. And as long as you've got justification for going against the guideline, there is no problem medico-legally. So we've got to teach people that as one thing. Investigations is another thing. Investigations largely have been done badly in hospitals because they've been, mind you, when I started in perinatal meetings where we presented cases that when things had gone badly, were dreadful. We stood up there and everyone shouted at us and told us how bad we were. And, I can't say that was a great environment either. But the thing was that to some extent, we also, our seniors appeared to trust us and help us, which meant you could cope with that in a way. You brushed yourself down and you get on with it. Lots of investigations now destroy people without actually getting any information to stop it happening again. And there used to be situations where people got removed from the area of service, but the system still was fault. So you just put someone else in who will make the same mistake about 6 months or a year from now. So what we should be doing is not looking at what did someone do wrong, but why did this occur and how could we stop it? That's why the HSIB investigations we set up, that's the purpose of that. Not, our investigations never named anyone in them. So they were all talking about what happened and what clinician did or whatever. So it's about guiding how best to change practice to stop it happening again. Not this is what happened here, if you know what I mean.
Thank you. Was there another question to that?
Thank you. You mentioned that people going out of the system is problematic. I suppose I think of the system as the NHS. But I was just wondering, is there a difference in outcomes between NHS and private hospitals and maternity setups, which have consultants and midwives and so on? Is there a difference in outcome between those two?
Well, there are very few private hospitals in the UK. I mean, it's even less than there used to be. There's only one main one, and that's the Portland in London. Now, what's interesting is, and there are others in London that are now closed because of complications that occurred and problems that occurred there. In Portland, if you look at it, there's a certain percentage of the consultants will largely deliver all the patients by cesarean section. So therefore, they don't have a lot of problems apart from complications of cesarean section. But if you look at the people who are happy for women to labour and support the labour, they have very, very good outcomes because you've got a doctor there most of the time looking after them. So therefore, if an escalation is required, escalation occurs. And they don't have high section rates in labour. They don't have all the things that people claim that happen. But that depends on the skill in the individual you're talking about. But private practice, in people who allow women to go through labour and support them through that, they have good outcomes. It's not worse outcomes, it's, if anything, better outcomes.
Okay, thank you. Questions coming through. Can I take a couple of questions from here? This is fascinating. Why can't the guidelines say attend to the desires and gut feel of women?
That's interesting. I mean, one of the things which I always said is that, and this was largely related to preeclampsia, I must admit, because that was one of my big clinical things, is that in some ways, if a woman says they're well, and I never totally believed that. I wanted to measure blood pressure and make sure everything was okay, because a lot of things that are going wrong, she may not be aware of things going wrong. But if someone says something that I'm not happy with my baby, I took that very seriously. And so because if she felt something's changed, then she knows better than anyone else. Just because I then listened to the baby's heartbeat or felt her tummy did not mean that her feelings were not correct. So I think that you're quite right, that if someone has a gut feeling about something not being right, then I think we need to take that seriously and follow that up and not reassure all the time. We shouldn't normalize things. We have a terrible tendency in modern obstetrics to normalize things. Say, don't worry, this is okay, rather than actually say, well, let's find out if everything's all right. And so that, and this is because we've classified this into low and high risk. So if you're a high-risk pregnancy, you do very well because the care you get is excellent. There's someone watching you all the time to make sure something doesn't go wrong because they're expecting it. If you're low risk, you don't get that level of care. People don't expect things to go wrong and tend to normalize the symptoms and feelings you have. So yes, listen to the gut feeling of the woman is extremely important because they can tell you an awful lot of things which you cannot pick up by the normal medical assessment.
When you talked about risk assessment, I mean, risk assessment, you're saying is a problem when you dichotomize it into low risk and high risk, and yet risk assessment was one of your core features. So how do we get risk assessment right? Because this often seems to be a problem that somebody is high risk, low risk, then they move into high risk, and they never really move back to low risk, or you ignore people who are low risk.
If you look at risk, we started with risk of looking at who requires cesarean section. There was women with rickets and so on. So you took people and you selected out people who required something. So you select out high risk. You didn't take the others and put them to low risk. They just weren't high risk. And the problem is that we've now classified people as low risk, and therefore they then become they're then looked at as something different.
Yes.
So risk is not a binary thing. It's a change. It's a graduation thing. So each time you look at someone, you should say, "Are you okay? Has there anything new occurred which might put you into a high risk category?" I don't think you look at things anything new occurred that puts you into a low risk category. That doesn't work. People should have a baseline point, and then they can work out about whether they're more at risk following that or when things change.
So we'd have normal risk and high risk,
Yes.
rather than low risk.
And it should be something which would, normal risk can change into high risk.
Yeah.
High risk can change to low risk depending on what the high risk is. If you're high risk of premature labour and you're 38 weeks, you're no longer at risk.
Yes.
You know, I mean, so things can change, but you've got, but it's not. But the important thing is you've got to assess the change. And you know, sometimes people present into day unit with high blood pressure, but in fact, at day unit, everything's normal. Therefore, you're brought in because you're thought to be at higher risk, but in day unit, you're then assessed as not being that bad.
Yeah. Okay. Thank you. There's a word which keeps coming up in a number of the lectures is paternalism, which somebody has brought up there, and it seems to be it's funny because you don't really get paternalism seems to be a recurrent sort of accusation, and you don't really get that in cancer medicine or in dermatology or in rheumatology or surgery. But it does seem to be something about maternity which people feel that somehow they're being coerced and pushed down a particular route when they wouldn't be if they were surgery. I don't know. And they said, well, I don't want surgery. You'd go, well, more fool you, but that's your choice. Whereas in maternity, and I guess it's to do with the fetus, isn't it? That people are trying their hardest to get it right so that the mother makes the right decision for the baby. And yet, well intended, but it's being interpreted as paternalistic and coercive, and to not do it and to not try and persuade somebody down the right route when you think this is very unsafe, what you're planning to do feels awful, especially if there's a bad outcome. But it seems that's what we should be doing.
Well, I don't think paternalism was something that just limited to maternity. I think it existed in medicine in general in a way. And I think a lot of that's changed. The other thing, it's difficult to think about paternalism in maternity since the majority of consultants are women. So the term paternalism may not be right, but it still may be a term about coercion or whatever. The problem I have is that I've always believed that to be a good clinician of any sort, you've got to have a degree of arrogance that you have the knowledge and you can do things and you can say you can do something which you think I know I can do this, but humility to feel that actually I might not be right and listen to other people and change your view depending on the circumstances. And the problem is that balance. Different people have it. Some people have too much humility and really never get to the point of making a decision.
Yeah.
And others are too arrogant and don't listen to people. So you've got to get that balance. But the problem in obstetrics is that informed consent is a very interesting thing, because informed consent is dependent on what information you're given. And a lot of the problems of people, again, now into rural risk category, they're told everything's going to be okay. And a lot of it, in inquiries and investigations, you often find that no one told me my baby was at risk. And that's one of the problems we had. The story which was told of someone who midwife called a doctor because of fetal distress in second stage. He wanted to do a forceps. The woman says, I want to push for another 10 minutes. They said, okay. No, in fact, no, they shouldn't have said that. They said, no, it's a bradycardia. We need to get the baby out, because what happened was the baby was delivered and is brain damaged. And that's our fault for not communicating that in an appropriate way. We tend not to want to coerce people or persuade people and allow people to make their own decisions. But they only make decisions if they've got the right information.
It's a very sensitive thing that whole situation of forceps births just at the time when things are going wrong is one of the most tricky ones, isn't it, for consent and coercion, but such a high risk situation as well. And maybe we only get it right if the trust has been built up all through pregnancy rather than suddenly somebody unknown at the time. Did you want to ask a question?
Hi, thanks for the great presentation. I just wanted to talk about racism in the NHS, which we do speak about a lot. Black women 5 times more likely to die in childbirth, regardless of socioeconomic conditions. Southeast Asian women 3 times more likely. Now those stats have gone down slightly, not because of improvements, but because more women are at risk in general, all women, because maternity has slipped. It's important to listen to the woman, obviously, because it doesn't matter if it's your first baby or your 10th baby. If the woman's pregnant, it's her body and she knows when things feel different. And we do find there is quite an arrogance amongst people in maternity. There's also tropes bandied around that black people don't feel pain, and the darker your skin, you know, the less you feel pain. And so I've seen women interviewed saying, I was in dreadful pain, I had some more medication, was told, oh, you're strong, you'll be able to cope, what have you. And some women have been told your screaming is not in tune with your contractions, which is lunacy. And I think you've hit the nail on the head there, because it's all the investigations, etc., and nothing seems to be changing. Having attended board meetings at the Women's Hospital for 11 years, and now because it's a joint trust, they don't have separate board meetings. But one of the things that was mentioned a few times was the recognition of when to escalate, and there was a failure in that. And time is of the essence, and it can be, you know, life or death within a few minutes. And so they spoke about that a lot, but it doesn't seem like things are changing, because, as you say, a lot of them are not trained to the standard where they can recognise that. And that's what's so important. And I have a few friends who are midwives, and one who trained as a nurse before she trained as a midwife said that is crucial, because you have all those extra skills to bring into the arena. So, and one of the things that always puzzles me, why do they allow women to go 2 weeks over sometimes before they induce? It doesn't make any sense, because the baby is at term.
Well, there's a lot in that there. To take the last one first, because is that it is an interesting question. And the work, which was actually done by my father, in fact, looked at prima gravida, people having their first baby, and showed that going post-term was dangerous, and therefore, the instance of hypoxia and also stillbirth immediately postpartum was dangerous. So that's why, certainly in Scotland, induction timing went to a term, or even 39 weeks, in fact. And when I trained in the Royal Maternity Hospital in Glasgow, it was 39 weeks in prima gravida. In Paris women, the risk was far less than that, and they tended to go into labour anyway. So, but one of the problems is that the date that most hospitals decide and when to induce is usually dependent on their workload. One of the things, our problem is that we don't staff our hospitals to cope with induction. We should actually plan induction, have induction suites, and properly accept induction, and make it actually a more comfortable and better thing for women to go through. And by doing that, we would make a big difference in how women are cared for and the outcome. So you could then bring forward the date of induction. The same number of babies deliver, so all you're doing is moving the time and a certain amount of effort over the time of that itself. Your comment about racism is a very interesting one, because you're right, the outcomes are clearly different. And one of the problems I always had is, that's fine, but let's find out why that is, and therefore we could then change it. And it's a multitude of things. And some of the comments you said about you're black, so you can cope with pain, or it's the women from the Middle East, for instance, they say scream and yell far more than they should do, etc. These are prejudicial things that people have for whatever reason. And that's something which it's something we need to train out, just as we do for any racist sort of approach or thoughts. But there's other things involved. Some of it's about language translation. And the thing is that people forget that a lot of the problems of language translation is at 2 a.m. when someone comes in, when you don't have someone easily there. And you may have a translation line, but it's not particularly useful, because there's often a man at the end of the phone, etc., etc. But modern AI might improve that. It may be that we're able to talk to people in real time using a translating system. That might help it. So I think but there's lots of things can improve, but we've got to work out why it's happening first of all, and then change it, and stop talking and pointing fingers at being racist, but saying, how can we overcome the problems that are occurring, which produces this situation?
It's not one model. You can't fit in there for a bad already.
Oh, I don't. Doesn't come in at night.
Fantastic. Well, we've got 7 o'clock, so I think we should finish off now. Thank you so much, Jimmy. That was fascinating. What a fascinating perspective on it. And we'll look to see, I guess, how the Amos team try and pull all this together in something which is workable and hopefully the government will respond to where extra money is needed, but also staff and women can also respond to. We've got a small memento to say thank you so much for coming to be with us. I appreciate your time in doing that, and thank you for accepting my invitation.
Thank you very much.
Thank you. Yeah. So next week we have Geeta Nayar coming to, not next week, it's 3 weeks' time, in fact, on the Thursday night. Geeta Nayar is coming to speak on how do we prevent birth trauma. Now this overlaps, but is different. And so somebody who herself has undergone birth trauma and is involved in the Birth Trauma Association, we hear a lot about birth trauma, but actually, how do we prevent that? What do we need to do in order to do that? So that's 3 weeks today, on Thursday, the 23rd. The other thing is that for members, there's drinks next door as always. I'm assuming everyone's here, member. If you're not, why not? Yeah, you should be. This is a membership organisation. Students free membership. Most other people are £50 a year, which seems to me a complete bargain. Active consultants in active practice, we ask to pay a little bit more, which only seems appropriate. But if you remember, come and join us next door for a drink. And if you're not, well, sign up online. Okay, thank you very much.